My name is Kelly Choy-Wilson, and I am a young advocate of Living Beyond Breast Cancer's Patient Advocate Training Program, and I will be acting as your moderator for today's program. In 2021, at the age of 42, I was diagnosed with stage 1 triple negative breast cancer. Being diagnosed with cancer was shocking and led to many challenges. Facing those challenges head on, I have gained confidence, strength, and learned a lot about myself. Today, I am healthy and thriving. We all know that the impact of breast cancer diagnosis reaches beyond treatment. And today we are going to discuss another side effect, the financial and time toxicity of breast cancer. After being diagnosed with breast cancer in 2021, I went on short-term disability right away. Unfortunately, because I had already used 1.5 months of short-term disability for another condition earlier in the year, I didn't have the full 6 months of short-term disability, which would have covered my salary until I was able to apply for and receive long-term disability. This left me with 1.5 months without pay, as if I didn't already have a lot to deal with. I reached out to my cancer center social worker, and she was able to provide me with grants that I could apply to for assistance. One of the grants that I applied to and received was the LBBC one-time grant, which led to my current advocacy. Thank you, LBBC. I'm sure that, like myself, many of you have also faced similar financial challenges. I am honored to introduce you to today's speakers, Erin Bradshaw, Executive Vice President for the Advancement of Patient Services and Navigation at the Patient Advocate Foundation, and Dr. Pallav Mehta, a medical oncologist, hematologist, Medical Director of Reimagine Care, and Assistant Professor of Medicine at MD Anderson Cancer Center at Cooper. To learn more about both of our exceptional speakers, please go to lbbc.org to read their full bios. We are going to hear from Dr. Mehta, who will discuss financial and time toxicity from a clinical perspective, and then from Erin, who will share some scenarios and provide strategies and resources. Welcome, Dr. Mehta.
Thank you, Kelly. Thanks for sharing your story and for shedding light on this really important topic that we'll talk about. So I have been an oncologist for 20 years, so I thought it would be helpful to look back and say, how has this issue changed? What is the evolution of financial toxicity in cancer? I actually remember distinctly the first patient I treated with breast cancer. It was in 2004, and I did my training at the Fox Chase Cancer Center here in Philadelphia. And it was a woman who lived in North Philadelphia. And I remember her saying that coming back and forth, the parking was a real problem, just the cost of the parking. And at the time, didn't really register as to why this would, why when you think about the cost of treatment, why this might actually be an issue. But over the years, clearly I've come to realize, and the community, the medical community in oncology has come to realize the importance of this term, financial toxicity. It actually wasn't even a word in our literature until about 2009, 2010, when we started to focus on it more. And today, almost every cancer center has some policy, personnel, and some process around financial toxicity. So in 2004, what was happening in cancer? So when you look at the treatments of cancer back then, 20 years ago, particularly in breast cancer, most of the treatments were chemotherapy. So we didn't really have targeted therapies. We certainly didn't have very many oral medications. The only oral medications back then were the hormonal agents, the estrogen blockers. And metastatic breast cancer, unfortunately at the time, really was limited in the types of options we had for patients, and the life expectancy was limited. And so patients were on treatment for much shorter periods of time. Even the patients that were cured from their treatment often didn't receive months and months, and certainly not years and years of treatment other than these hormonal agents. Even the supportive drugs that we had, so the medicines that we use currently for prevention of nausea, prevention of diarrhea, keeping our blood counts uh, stable during treatment. We didn't really have too many of those. And if we did, our guidelines at the time told us not to use them unless there was a problem. So we didn't really use things preventatively at the time. Genomics, which is its own conversation, but the whole field of genomics, all the testing we do for the different nuances of the breast cancer and the different targets we look for really didn't even exist as a field 20 years ago. And even genetics, which is when we look at a patient's genes and trying to determine if it's hereditary, if the cancer is hereditary, even that testing was very limited. The only genes we actually knew about were the BRCA1 and 2 genes at the time. And today we have dozens and dozens of genes and more to come. I think one of the most significant issues, though, is this out-of-pocket cost. So in 2004, there was actually a change in the tax code that incentivized employers to start offering what was at the time called these high deductible health plans. And for those who had health insurance at the time, you remember that the maximum out of pocket with most of the previous plans used to be somewhere around $500, maybe as high as $1,000. The high deductible plan, the idea, of course, was the deductibles went up, so the premiums went down. And the idea was to then potentially cover more people and allow consumers, which really is another name that an insurance company would give a patient, consumers to be more involved in their choices. The problem with that, of course, is that when it comes to certain things, the involvement a patient can have in choosing it could be limited. If you're having a knee surgery, there may not be an urgency to that. You have time to think about all the different doctors you could see and the different places you could go. But when you have a breast cancer diagnosis, you know that time is more limited in finding who you want to get the treatment started. The other sort of big change has been where cancer is treated. And most cancer at the time was treated in what we call community practices, which for most patients could be just a few miles down the road. And there were hundreds, if not thousands, of these community practices made up of a few physicians, a few oncologists, sometimes 2 or 3, sometimes 10 or 15. But a lot of these small practices thrived in the community, and the bigger academic centers were about 25% of patients were treated. Those were used more for second opinions, and then the patients would go back to the community. And oncologists themselves, we just didn't think about this at all. And it wasn't part of our conversations. It wasn't part of our literature. But flash forward 20 years later, and now we think about all the therapies in breast cancer, and breast cancer really does lead the way, which is great. But all those therapies are costly. Targeted therapies, immunotherapies, biologic therapies. And our metastatic patients now, thankfully, because of our success, are living much longer, and many of them even in a chronic disease type of situation. So you have more people getting treatment and more people getting longer and longer treatments and staying on treatment. And those oral agents, for anyone who's been on a targeted oral agent for breast cancer, knows that the cost of those is astronomical, somewhere in the $15,000 to $30,000 a month range for a medication that may be 1 or 2 tablets a day. The supportive drugs, again, this has been a great advance in all cancer, particularly in breast cancer, that the days of women vomiting in the chairs, we really don't see any of that anymore because our nausea meds are tremendous. Our ability to keep immune systems healthy has been tremendous, again, at a cost. Genomics, we test patients' cancers for all sorts of things now to decide on treatments. And then, as I said, those high deductible health plans, the majority of patients now are on high deductible health plans. And a lot more cancer as those community practices, which I initially started my career in a community practice. Currently, I'm at an academic medical center, but all those community practices either shut down or due to various changes in reimbursement were bought by larger systems, which has changed the fee structures. And hospital-based systems have different cost structures, have different needs. They have larger personnel, they have more services. And so there are different fees associated for patients, not to mention that these are usually not right around the corner for most people. And so you're talking about transportation and driving long distances and parking, and it's just a much more involved treatment during that day. And as oncologists, thankfully, we are now aware of the problem. I make it a point in most patients that I see that as at the end of our visit, I always ask them, how's it going with the costs? What's are we okay with copays? And if not, I make sure they're connected to the right people on my team. Next slide. So what can you do about all this? And Erin, I know will get into much more detail about this, but as an oncologist, what do I think about and what do I think a patient can do? I think understanding the costs. Now that sounds easy, obviously quite complicated. I feel like most of us need a degree just to understand what insurance covers what. I remember I had an MRI of my knee last year that was covered and authorized, except it was over $1,000, which I didn't realize that's how that covered is not always covered. But understand if your cancer center has a financial counselor, because now many, if not most, have somebody whose responsibility it is to communicate with patients to talk about the cost. Ideally, before you ever start. If you're about to start a 1-year regimen of chemotherapy, Herceptin, and an oral medicine, you want to know before you start what sort of costs, not just the cost of treatment, but the cost to you that you're looking at so you can budget appropriately. Financial assistance programs are available. A lot of this money does not get used. There are nonprofits that clearly are helping. Pharmaceutical companies have programs. Hospitals and cancer centers have programs, particularly the larger academic centers have programs. And don't forget about crowdfunding. It's a newer way to raise money, but it is something that has been successful for a lot of people. When you think about friends and family and even strangers, when someone has cancer, we want to help. And sometimes all we know to do is, bring over lasagna. But you'd be surprised how people really need, you can band together 100 or 1,000 people, how the community can really support a patient undergoing treatment. Maximize prescription savings. There's these online comparison tools out there. GoodRx is one of them. Using generics and take advantage of virtual and on-demand care. This is something that I personally am very interested in. I'm the medical director of a startup company called Reimagine Care, which looks at virtual and human-based extension of cancer centers. There's different uses of telehealth and texting technology and even in-home care that can be done in various parts of the country to make it easier for you. And the bottom line is speak to the providers, because I think if there really is one thing that's changed, it's that we want to hear from patients. If a patient doesn't tell me, I won't know that they're having an issue, but I'll hear from somebody else that they may have looking at declaring bankruptcy. When really look at the options of treatment, you would be very surprised at how, as oncologists, we sometimes favor one treatment or another, not necessarily because it's better, but just something because we're used to it and because we've been giving it for years. But for certain patients, that one treatment versus another equivalent treatment could be thousands, if not more than that, less for them. So have that conversation. Have the conversation with your nurse practitioner, your oncologist. Think about treatments. Think about the frequency of visits. They may want to see you every week, but ask them if that's really necessary. You'd be surprised. It may not always be necessary to see a physician every time, because each of those visits has its own copay. Think about imaging tests. You really need a CAT scan every couple of months, but these are things you want to have conversations about. So be ready to have those early on and set that stage with the providers so that your expectations and their expectations are appropriately aligned. So I'll stop there and hand it to Erin.
We know that navigating the cost of care, as was just presented, is really something that many people face at all different types of where they are in their journey and their diagnosis. And the term financial toxicity really describes for us the practical and the emotional impact of the cost of care on individuals and family while they're managing their breast cancer diagnosis. So during this session, I want to share a little bit more about Patient Advocate Foundation, some of the areas of support that we offer, as well as use some examples to demonstrate scenarios that you might find yourself in or might see yourself in the future as we talk about the medical cost as well as the insurance navigation. So Patient Advocate Foundation is a national nonprofit charity, and we provide case management and financial aid to patients with all different types of life-altering or chronic disease. We were founded in 1996 and really was based on an individual who had experienced some challenges when navigating their own breast cancer journey. We have helped 2.5 million patients since our inception, and we are really there to provide that support around those administrative barriers that often present once diagnosis that exceed outside the clinical setting. And as you can see, we've provided a lot of direct financial support, but in particular within case management, our role is more of an intervention arm about helping people navigate to the best resources. And with our support last year, we did about $18 million in debt relief on behalf of people. So it's 5 out of the 10 issues that people call us about are actually around the disability, health insurance, and out-of-pocket medical costs. And I do see in the chat and some of the questions that this is arising, and I'm sure we'll have some time to speak about that towards the end. We recently conducted a survey, which I thought was very powerful and really clearly demonstrates the burden of administrative tasks to individuals that are navigating the system. And I just wanted to kind of set the stage with this because it really just describes the ever heightened need for resources like Patient Advocate Foundation, as well as others that were mentioned prior through other navigators, social workers, counselors within the hospital, to really help get through a lot of the complexities and often uncertainty around safety net resources or financial solutions that might be there to support you as you navigate your treatment. So case management is a one-on-one intervention. I want to spend a brief moment just talking about it. It is the heart of why we were founded. It's helping you get services through the ecosystem of all safety nets available. So you'll notice 3 major buckets. You got health insurance navigation, helping you determine what benefits you should pick from. And you're going to notice a bit of a theme between both of us presenting around some of the common areas that we really want to focus on. There has been a lot of evolution around health insurance design. There also might be some changes in your healthcare needs that maybe the plans that you are currently on may not meet your current needs moving forward. And so I highly encourage, and I want to just put a plug right now, it is open enrollment for Medicare and will be Marketplace. Also keep in mind with all your employment open enrollments to always assess and look at what plan options you have available to you, screen against all of those, what kind of treatment you're on or you might be projected on. Also, and just kind of determining from medication to providers to networks, it's always a great idea to look at the overall cost between your premium as well as your out-of-pocket cost. And so all of those core competencies are what we provide help at case management. But also, if you're running into a situation with your insurance, you have with denials or appeals, or maybe there's a coding error, or you just don't quite understand why something's not being covered, those are areas that we can provide aid to, as well as disability navigation. So if you are looking at screening yourself against that, you're an able body moving into a disabled body and not wanting to know what kind of benefits you potentially are eligible for, help with application, help with the appeal process if you find yourself there, as well as all the support for financial hardships and exploring external resources to reduce those medical costs and everyday expenses, and even helping with those applications. So I'm going to focus on when insurance arises and then how to manage medical debt from a very high level, and then answer some questions after. So we know that as you navigate through your healthcare journey, there are lots of roadblocks that might present. So insurance, as I mentioned before, some of those unknown circumstances of out-of-pocket costs, and you might find yourself in a situation where you're going to the pharmacy and maybe going to pick up a medication and really didn't have any transparency around that cost. And it might be you might find yourself in a position to utilize funding that was saved for maybe a mortgage or a utility to get that medication, or you might walk away. And we don't want that to happen. We want to make sure that we really explore all possible solutions so that you have the treatment that you've been prescribed and that you're able to move forward with your care journey. So employment protections and workplace entitlements are an area that we want to pay a lot of attention to. So if you might not be familiar with everything that you have available to you. Do you have short-term or long-term benefits? Are there any auxiliary benefit support or discounts? Your health insurance through your employer, or in those areas, as well as some of the protections that can protect you from your job, such as like family medical leave, or if you're moving into an opportunity where you might have to transition out of the health insurance that you have. Just being sure that you understand what they are so that you can best utilize those resources should you find out that you might have to transition into a disability state and or maybe not be able to work for some time. You don't want to lose any valuable benefits. And we all know that as you navigate the journey of your care, that the cost of living really can be very impacted, because if you have to find yourself in a reduction in income or the large out-of-pocket expenses that were unexpected, they really do cause a challenge. And so those are probably often resources that you're not familiar with and really would benefit someone supporting you and navigating you and asking the right questions to connect you. Start with a couple just basic terminology around in this topic of navigating insurance. So in this case example that I'm going to be talking about, we're going to be talking about someone who has run into a insurance denial. So there are really different levels of appeal types and prior authorization. So denials before services are rendered, post-treatment. So you've denial for payment of care that you've already received, and then there's urgent or expedited appeals. So there are opportunities where you can request an urgent overturn and that often is supported by a provider and medical evidence to quantify the need of a quick turnaround. But I just want to kind of pause for a minute to show that you can see there's a lot of timelines associated with it, and sometimes they're not that quick. But they're also very critical to stay within the timeline so you don't lose out on the opportunity to contest a particular denial. Oftentimes, your provider is a huge advocate for you. We at the organization also provide some administrative support in gathering and putting those things together for you too, through all different levels of appeal. So for the purposes of this conversation, I'm going to use Sandra. She is a 64-year-old female and lives in a suburban area with her husband and 2 dogs. Her children are grown, but live nearby and are frequent. She was diagnosed with triple-negative breast cancer, also has diabetes, and has completed her chemotherapy as a mastectomy. She works as a contractor, so that means she doesn't have benefits through her employer, but she was covering herself through an individual PPO that she purchased through the healthcare marketplace. Some of you might be familiar with hearing the Affordable Care Act. There might be heard the terminology Obamacare, but this is an opportunity for people to purchase insurance when they don't have other benefits available to them through their state. So now that she's recovered from her mastectomy, Sandra's oncologist has wanted to try a new chemotherapy regimen, and the insurance plan has denied the coverage of this treatment, citing that they're classifying it as experimental investigational for her cancer type. So in this case, we would want to understand what is the reason for denial, and then look at her insurance plan's appeal process. And they might have an internal process. They might, there should be a letter or something that gives us some summary on how to appeal and some timelines. We would want to work with the healthcare team and gather information. like get a letter of support from the healthcare team, including reasons why of medical necessity, obtaining any supporting medical charts, testing, or notes, and obviously staying organized and paying attention. All of this can be very overwhelming and also can be difficult to keep track. So if you have someone who's close to you that wants to support that, or there's an advocate or even a hospital support system, really the goal here is to be very factual, to come up with contesting reasons and hopefully overturn this scenario. In this case, we were suggesting a peer-to-peer involves a discussion between the prescribing physician and the medical director at the insurance company. This is a stepping stone before you actually get to a formal appeal, and the provider can share things like medical or treatment history or details about the condition. Medical directors can use their own judgment and overturn this denial at this stage so the patient can pursue without treatment. So this is often coordinated between the provider and the insurance company to a scheduled call and there. And this is probably often done without you really necessarily knowing that's happening because your providers are there to try to really get to the treatment that you need at the most proficient way. For another angle, I'm going to talk about common terms. So insurance is very complex, as mentioned before. And so not only do you have a premium, but that's a monthly pay that you're paying each month for your benefit, you have a deductible. And a deductible is the amount of out-of-pocket cost that you're responsible for before your insurance begins to pick up some additional cost. You'll hear some variables like co-insurance, which can be a percent of a particular treatment or procedure, or a copay, which is a set amount. So maybe $20 to see a specialist, or $50 for a particular medication. And then there's an out-of-pocket maximum, which is where the plan is required the patient to pay up to a certain amount. And then after that is met, they should be paying at 100% of in-network and covered benefits. As you explore your insurance options, you want to look at the overall cost of the year. So what is your premium? And then there's a mathematical equation that could be helpful to making sure that not only have the benefits that best suit your need, but also which one might make most fiscal sense. And that is really a personal choice. I will share that there are great resources by Triage Cancer that have these worksheets that you can actually fill in to kind of look at that comparison as you're looking at these type of decision-making factors. The other thing is you want to make sure that your plan is paying in accordance. And so the explanation of benefits and those things are good to map against what you understand your benefit plan should be paying, and making sure that there hasn't been some oversight or lack of insurance submission so that you're not paying more than you should. So Mara is a 37-year-old, lives with her husband in the city. She's got stage 2 ductal carcinoma, and she works as a graphic design artist for a large nonprofit and has a high deductible health plan through her employer. The cost of the oral chemotherapy, along with her medical expenses she's incurred from all the testing as well as lumpectomy, has become a substantial financial strain on her and her family. So what we would want to do is look at any charitable copay program that might exist to help cover some of those out-of-pocket costs for her treatments that she's having, and screen her and see if there's eligibility for copay, co-insurance, deductibles, and sometimes premiums. There may be a manufacturer copay card as well. So we'd want to look at the medication she's been prescribed and go and see if they have a copay card or discount card that she could apply towards her insurance to reduce that out-of-pocket cost to make it more affordable. Sometimes they can be as low as $5 a month. The other thing is this is very much mirroring what was shared before, but I think it's great advice, is discuss with your doctor. They're very aware of how expensive treatments can be today. They also want to make sure that you're getting access to the treatment you're being prescribed. There might be some negotiating factors on a bill that you can't afford, whether a payment plan or discount, whether that's through the facility or the provider's office themselves. They might have their own charitable program, be able to map you to an asset within the hospital or provider to screen you against any available financial assistance, as well as if you have a health savings account. In her case, she has a high deductible plan. So has she contributed into the health savings account, which is something that you can take pre-tax dollars and apply to pay some medical expenses and cover that deductible and out-of-pocket cost. Sometimes if you're insured by an employer, they might also be contributing into that. And so want to make sure you're utilizing every valuable resource that you have. And then, of course, always have to say, review your plan options every open enrollment and just ensure that you have the best plan that suits your current treatment needs. I just want to call out a resource that you may or may not have heard of. It's called $4, and this helps patients navigate hospital financial assistance or charity care. It is very specific to hospitals that have received federal funding, and there's a pre-screening tool. You can go online, $4.org, and it does help. Doesn't help with any other medical things like appeals and negotiation, but it does very seamlessly connect you to any financial assistance that you might be eligible for through the hospitals that receive federal funding. I just want to call out, we have an educational resource library, education at patientadvocate.org, very robust. We have a national financial resource directory that you can go to and put in some specifics about yourself, and it will give you an opportunity to explore vetted resources that we have been adding for years around whether it's disease specific, state specific, topic specific. We also have some educational materials around how to appeal, the disability process, medical bill management, and more. And then these are our websites. So patientadvocate.org will actually connect you to all of these resources. Our case management services I spoke about earlier. We do have a copay relief program to help with some out-of-pocket copay costs. We have some financial aid funds. There's a scholarship for survivors, for individuals that have disease has impacted their education journey. And as well as there's our National Resource Center and Resource Library. In closing, I'll just share one of our testimonials that were recently received, and I think this will resonate to the topic that we're speaking about. But this is Kimberly, and she has breast cancer, and she came to the organization because she was she had $24,000 in outstanding costs and could not understand how come it was not being covered by the insurance. And so our case manager worked with the hospital and insurance to try to figure out why there were so many bills. And there ended up being some incorrectly filed bills that were not able to be solved very seamlessly. And so our case manager stepped in and took over this burden for her and put together a plan and got this all coordinated, which ultimately ended up with it being paid in accordance, which was super supported to Kimberly specifically. But I think the biggest thing I want to mention here is that if you notice these things, it's really important to say something very soon, because there are timelines associated to rectifying any kind of insurance and billing scenario. And we wouldn't want to miss that timeline when there are mistakes that can happen.
Thank you, Erin and Dr. Mehta. I just want to encourage everyone, if you have any questions, to enter them in the Q&A, and it does look like some more are coming in. I did want to start with a question for Dr. Mehta. Based on my personal experience and seeing some of the comments in the chat, it's very stressful to get a cancer diagnosis, go through treatment, and then also deal with financial issues. So what do you recommend to your patients when they are mentally exhausted or stressed from dealing with these type of issues?
Mm-hmm. Yeah, it's an important question. It's something, again, that as an oncologist, because we're just more aware of this issue now, and because communication has gotten a lot better between patients and the oncology team and the additional staff we have and the oncology team, the awareness alone allows us as oncologists to always have in the back of our mind about this potential problem. And I'm not alone in saying that, asking patients about cost and how it's going is a part of our routine for a lot of us. And when you do that, I think it validates this issue, because what I've used to see was patients would feel guilty even mentioning the cost issue to me. And I think that was partly because you feel like you're fighting for your life. And so, God forbid, you could mention anything about the cost. But again, that communication and having that direct communication from day one with not just the oncologist, but the other team members, and knowing who those team members are that can help you is really important.
Mm-hmm. Thank you. We have another question for someone who is stage 4. wondering what other resources besides Social Security disability they have because they haven't worked enough to be qualified.
So I can speak to that. So Social Security disability actually has three options. You have Social Security SSDI, which is relative to the work credits and quarters that you've paid into, which sounds in this case has not worked enough. There's supplemental security income, which would be dependent on income and asset in the household. Sometimes people fall into that. But in not knowing specifically this individual's background, if they happen to have a household income from whether a spouse or that might disqualify them. And then the other option would be from a retirement standpoint. And then they're depending on the state of the individual and where they live. Some states have some short-term type disability. And then if they had worked, but outside that, it would be probably mapping to potential resources to, and that would require us to probably work very specifically with that person, understand their location, where they are financially, to give them a really well-rounded answer. That is one of the challenges with disability is that it does have some very specific guidelines associated to it.
Okay, and I do see another question that mentioned national resources versus state by state. So would your organization be able to help people navigate what's federal versus state to state issues?
We would, and I think you have such great assets from a local standpoint, from your community action agencies, as well as your social workers at the location that you're at. We can do the same thing, but some of those can be usually more top of mind if they're in your back community. But certainly that's what we do.
Is it possible to apply for SSDI while still working, but anticipating that you might need it?
The way that Social Security defines themselves is that you're not able to work or your condition is going to exceed like 12 months. So there's a 12-month break and you can't apply when you're working, unfortunately. It's kind of a catch-22 because obviously you need some income for that. If you have employment benefits, that would be ideal. That maybe you can have some short-term or even long-term benefits. The application for Social Security disability does take a little bit of a time. And so there might be a gap where you're waiting for decision. So I saw another question in there about like, how do you decide? And I think that's such an individual conversation. And I think a provider can be a really good support system for that too, because of the guidelines around disability themselves. They want that you're unable and won't be able to work a 12-month plus out. And if you have a condition that might be, there are some compassionate allowance conditions or things that are considered escalated due to the stage or type of disease that can fast track some of the decision making.
Can you talk a little bit about time toxicity and how to address that?
Yeah, that's just as I mentioned, financial toxicity started to enter the literature of oncology maybe about 15 years ago or so. Time toxicity is a newer kind of idea around what patients are going through. So financial toxicity and time toxicity to some extent overlap because it's all the time that patients are spending on their cancer. And so obviously that includes the treatment itself, which, that may not be able to change, of course, because you need your treatments and they have to be over a certain period of time and certain frequency. But other things, just the drive, how far away is the cancer center, the transportation, the walking to the place, the labs, the imaging tests, and then all those calls when you're on the phone and you're dealing with insurance companies or dealing with the schedulers at the cancer center and at the surgical place. And I've had patients tell me, the day before they were on the phone for 3 to 4 hours just trying to deal with one issue. And so this is, again, is something that we are starting to recognize in the oncology community, both in my role as a breast oncologist, but also in my role at Reimagine Care. It's something that we're talking a lot about and trying to understand the specific issues around it and where we can intervene. I think one particular place to intervene, I'll mention one from the oncology side of things, is again, when you have those conversations with your oncologist, there may be options that are not as frequent. For example, I had a patient who I had recommended a treatment where she had to show up 12 times so once a week for 12 weeks for a treatment. But she just couldn't. She had a young son who was on the spectrum and she had to take care of him and it was just too much. And so we just changed it to 4 doses instead of 12. Just as good, but had she not told me, it wouldn't have, I would never have known. On,
Wow.
on, on the Reimagine Care side, this is where I think virtual, on-demand, care online, use online access. A lot of centers have good access for appointments. Don't get on the phone for those if you don't need to. Understand even insurance companies and how their online portals work and processes work. And so you can save yourself a lot of time just understanding some of the technology and those options that are available.
Can you speak to us about Reimagine Care? Tell us a little bit more about it.
Mhm. Yeah, so Reimagine Care is a venture capital funded startup company founded about 3 years ago to address the needs of patients on treatment. We recognized that patients on treatment, when they're in the cancer center, they're taken care of. They have their nurses and the doctors and the team is kind of enveloping them in the care. But once they leave the cancer center, the ability to get back in touch and the ability to just get questions answered and symptoms dealt with and all of that suddenly kind of reverts back to what we used to do, 50 years ago.
Mhm.
And so we address that with a virtual, but also human. We have nurses and nurse practitioners and a virtual AI-based digital front door that we employ to have patients have 24/7 access to their cancer team. So we're
Wow.
just an extension of cancer centers, and we serve just to help patients get through the entire process: chemo, radiation surgery, oral medicines, whatever you need, we're there.
Wow, great. So for a patient that has an oncologist that has not brought up finances, what's the best way for them to bring that up to their oncologist?
Literally just like that. Bring it
Okay.
up. Because I can assure you, the oncologist, they want to know this.
Mhm.
And they're not going to know the answers. As Erin was answering those questions, I'm learning a lot, by the way. So thank you for that. But the oncologist won't know the answers most likely. But the fact that they know that, they want to help. Yes, they know they have to have certain treatments but if they can just get some answers for patients, they feel like they're doing, I always say we treat patients, not cancer,
Mhm.
as oncologists. And if we're treating patients looking through that lens, finances are sometimes a bigger issue in patients' minds than the cancer
Mhm.
cases. And I've seen that.
Yeah, it's unfortunate.
Mhm.
Erin, I just want to confirm with you that the services at PAF are for not just for breast cancer, but for other diseases and chronic illness as well.
So we served almost 1,000 different unique diseases last year. So unfortunately, the areas that we're talking about span across all different types of support need.
What qualifies as medically justifiable for someone to remain on long-term disability after chemo?
So for it's really typically it's based on the insurance. So long-term disability has its own contract, right? And so there you're going to have to persuade the insurance company that you meet the standard of disability set forth under their plan or policy.
Mhm.
You have to prove that you cannot perform the material duties of your regular occupation, although some policies might require proof that you cannot perform any occupation, that you're suited by education, training, or experience. So I think we have to invest a little time understanding where we're at. And after chemotherapy, they might look at things like side effects, you know, there are other comorbidities that you had prior to, like, because we have to look at the holistic approach to see that. And they're going to probably request medical charting and reviews and validation to base those type of questions about their role. So if you're there and you're having to provide that information, or even if you're at a place where they might be denying or it's coming to a close, seeking that out and investigating it sooner is ideal, so you don't find yourself in a gap.
Mhm.
I'll add to that just briefly that when you, as a patient, knowing the team, the oncologist, nurse, and nurse practitioners, and let them know that there's certain words that have to be put in the documentation. It's the simplest thing, but as oncologists, we're dictating notes all the time, and we'll forget, especially if that dictation is a couple of days later, we'll forget to say certain things that might be so relevant to get those funds. And so just, make sure that the team is aware that, this is what they need to get this. And I assure you, it'll get there.
Yes, that's a very valid point. I actually sent a
Mhm.
message yesterday and put exactly what I wanted in the document. So yeah, that's definitely a good point to let them know exactly the wording of things that can help in your situation. So let's see what else. What about financial support for out-of-pocket expenses for really beneficial support care like acupuncture and massage?
So most insurance companies have a tendency to not pay for some of those elements. Acupuncture might be a little different, but we have to look at the plan design and what's covered or considered excluded. You might find that information in the exclusion section. And then outside that, it's kind of creative fundraising or support from our experience. But that's, I think if it's prescribed, I think it changes it versus, and it can still be prescribed, but it might be considered alternative care. And that, yeah.
There are some organizations like Unite for Her where you get a passport for those type of services, massage, acupuncture, those type of items. So that's just my input for that question. So Erin and Dr. Mehta, do you have any additional comments to kind of finish up with? Or have we touched on everything already?
I think we did. This is really, I think, comprehensive. It was helpful for me, for patients. I think understanding your team, communicating with your team, knowing if there's the right people on that team to address these issues, and really not being shy about it. I think there's a pride component that clearly goes into this when you're dealing with cancer centers and a diagnosis like this, but just leave that at the door. No one is judging. People want to help and the funds are there. So let them help.
You're already having to navigate this journey, and this is a lot to, and so it bring in the reinforcements and the support systems to help you. We wouldn't expect for you to have a foundational understanding of all the potential assets that might be out there from the years of experience that some of us have sit in our roles, or the support systems that exist. So, but we need to know, and so just be okay and reach out, and hopefully we provide some everlasting education and guidance. So in the future, maybe you can be of aid to someone else that might need the help. So it takes a team. So
Thank you. Thank you so much, Erin and Dr. Mehta, for joining us today and sharing your expertise. This was a great discussion.